Good morning, future PTAs. I hope you guys are doing well. All right, today we will talk about autism spectrum disorder. That is a complex neurodevelopmental disorder. It's characterized by difficulties with social interactions, communication, and repetitive behaviors. It can be associated with genetic disorders, and it's one of the most common pediatric diagnoses in the U.S. It's also one of the ones that's growing the most rapidly, whether that's because more people are having it or it's more commonly recognized and diagnosed. We're not exactly sure, but the prevalence is increasing quickly. The DSM, that is the manual that is used by psychologists, psychiatrists, medical doctors to diagnose different disorders. And so it characterizes autism as a autism spectrum disorder. It used to be differentiated between several disorders like Asperger's, but now they're all included under autism spectrum disorder. So autistic disorder, Asperger's, Rett syndrome, childhood disintegrative disorder, and pervasive developmental disorder, not otherwise specified. All those are included under the term of autism spectrum disorder. In order to be diagnosed with this disorder, then a child would need to exhibit at least two of the deficits from the first category, which are three deficits from this, which is impaired social communication or interaction, and at least two of the restricted repetitive behaviors. So they may have trouble with imagination or imaginative play, or with social interactions or emotional reciprocity. So understanding other emotions or exhibiting their emotions. That as far as repetitive and restrictive behavior, so echolalia, that's like when you repeat what somebody else is saying versus like coming up with your own thought and just doing a sentence that you created. You're just repeating what somebody else is saying. Some of the other common restrictive or repetitive could be movements that they do over and over, or a specific thing they say often, or just anything that they repeat continuously could be in that. These children have a lot of trouble with imaginative play or with peer interactions. And so, that's really key. We've talked about in other pediatric PowerPoints how important it is to play in order to develop all the different skills that you need for life. Play is kind of the foundation that we build that on as children. Some more criteria. Again, you don't have to know this super well. This is just kind of for your information. A lot of this lecture is typically the symptoms are present early in childhood and would need to cause significant functional limitations that aren't explained by another intellectual or developmental delay or disability. The CDC has done a lot of research and put out a lot of data about the prevalence of autism since it is growing quickly. You don't have to memorize this, but this is just kind of something that you can see for your information. Why is the prevalence increasing? We don't know. Once again, it might be because we're diagnosing it a little bit better. It might be because it's actually more prevalent. Studies have basically looked at all the causes and concluded that it's related to a genetic predisposition combined with environmental factors. So something is going on genetically that makes you more likely to get it, and then something in the environment most likely would push them over the edge in order to make the symptoms prevalent or make them display. Can't think of the right word for now, but that's what studies are gathering. So some of the genetic predispositions, anyone with the following genetic disorders is more likely to also have autism. So Fragile X, Rett syndrome, Angelman, Cohen syndrome. Doesn't mean they necessarily always do, but it's more likely. Teratogens are agents that can cause damage to a developing fetus. So both of these listed here are medications. That thalidomide is a medication that's sometimes used for nausea, and it could actually be a sedative, like to help with sleep. But it was found in the 50s and 60s to cause significant birth defects like limb abnormalities. And it has also been uh, proposed to be connected to the prevalence of autism. Another one is valproic acid, and that is a seizure medication that can also be connected to the prevalence of autism. Some of the risk factors in the incidence of autism would be advanced parental age. So a mom or dad that is older when they get pregnant with the child. Preterm birth and low birth weight have both been associated. Hyperbilirubinemia, so more increased bilirubin in the bloodstream, could cause it. And then if a child has a sibling with autism spectrum disorder, then they are more likely to also be diagnosed with it. Sensory processing. The majority of children with autism spectrum disorder have issues with sensory processing. They might have hyperreactivity, where it takes very little stimulus in order to cause a big reaction, or hyporeactivity, where it takes a lot more stimulus to cause just a general reaction. So they may seek more stimulus, and some of the behaviors you'll see in people with autism that are seeking more stimulation is hand flapping. That gives them some more proprioceptive input, but also visual input. You may see head banging, which helps them know where their head is in space, which is why they're doing it, because they're not getting enough sensory input. Rocking, humming, things like that all give really good sensory input that they're seeking, that their body is just craving. They may avoid sensory input. So it's common to see someone toe walking, like the baby in that top picture, where they're not wanting to put their whole foot on the ground because they're trying to feel as little of the ground as possible, especially like grass or some different surface. And one bad thing about that is if they continue to toe walk, eventually the heel cords or the Achilles tendon will not be stretched out enough to allow them to walk flat-footed, to walk with their entire foot on the ground. And so sometimes they'll have to have a surgery in order to lengthen their heel cord or lengthen that Achilles tendon and allow them to stand with their feet flat on the ground. So if the toe walking continues, it becomes more and more of an issue as they grow and their body isn't able to actually maintain that length. One of the common things you'll see in general, especially with autism spectrum disorder, but you see it a lot with children who have ADHD, or even children who are meeting all their developmental milestones. You might see it is sensory seeking, where they are craving that additional sensory input. So it may be because they have low proprioception and need more input to know where their body is in space. Often they'll run into objects on purpose. They might slam into things or hit things. These type of children benefit from swinging motions, from water, because that hydrostatic pressure just really calms the system and adds that input. They also may benefit from deep hugs, where you're just doing a nice deep hug down the surface of their body. That picture at the bottom is a really cool machine with the balls where you can like roll yourself through, and you're kind of getting that pressure, deep pressure in general, whether it's body hugs or joint approximation like we've talked about before, or just giving deep pressure throughout their body, like up their arm and up their legs, can all give that sensory input and prepare them to be able to sit and learn, to get to kind of their good, like their ideal level of input. to be able to self-regulate. So there's a motor theory. So some people are kind of like revving too high, like their motor is like too high and they need to come down a little bit. Some, their motor is not high enough and they need to come up a little bit. And so if you have somebody that's like hyperactive and they're just like, and can't settle down enough to like sit and listen and learn something new, or if you have somebody that's fallen asleep and they're just not alert enough to even hear what you're saying, you both need to kind of come to that middle ground is the best area for learning, and really for participating for anything. So, I mean, we all get that. Sometimes, right now you might be tired and starting to fall asleep, and that's not an ideal environment for learning. Or you might have a million things on your mind and you can't calm your mind enough to really listen and absorb what we're saying. So everybody in the world can benefit from coming to that middle ground. So what does it take to get you there? I mean, it's different for every person. Somebody that's really low um on the sorry. Now, I have a issue with words sometimes on the scale. It really needs to be, woken up and their motor needs to be revved up a little bit. Maybe for you, it might be coffee. But for someone else, it might be getting up and taking a walk. I have found that crawling is a great thing for children who are really low in their attention and they're, maybe on the verge of falling asleep. Crawling, jumping, swinging is great because it can bring somebody that's high down low, or it can bring somebody low back up. Water can do the same thing. It helps people get to that middle ground. Bouncing might be good to do that. So a lot of the same activities can bring people to the middle, whether they're low on the scale or high on the scale, because it helps them get the energy out if they're running on high, and it helps them wake up if they're on low. So exercise is great for getting someone to the point where they're able to learn better. So a lot of times what we would do in the clinic is if somebody was doing like PT, OT, and speech, they would either do PT or OT before they did their speech therapy, because oftentimes that movement got them kind of to that good learning zone so that they were attentive enough to be able to learn without being, hyperactive and not able to settle down their brain and learn. And so you'll see sometimes after somebody's swinging, or especially after they've maybe ridden a horse, like hippotherapy or something, that they'll say their first word because they're finally at that point where they're regulated enough to process things in a way that they're able to speak or to learn. Some of the other associated problems are language problems, motor development, problems with gait, posture, motor planning, coordination, and low muscle tone. So a lot of this we can work on in physical therapy, work on strengthening, work on balance, that we could do with the general population. But here, a lot of what we're doing is trying to get them to be able to participate in play and have more peer involvement so that they can do those learning tasks. To be able to sit upright in a chair long enough to get through the school day and learn, to be able to walk in the hallway without help, without, losing their balance, things like that. Some other common problems that you'll see with people who have autism spectrum disorder can be an intellectual disability, epilepsy, personality and behavior disorders. And the more problems that they demonstrate, the more likely they'll need some additional services. Some early signs of a child having autism, it could be that they have a low interest in people, especially limited eye contact. Lining up of the toys is a really common thing that is associated with autism, not because lining up the toys is bad, but because it's showing a lack of imaginative play. So taking a car and going vroom and acting like you're driving is imaginative play. Just sitting it behind other cars and just lining them up in order is not imaginative play. So that's why that is a sign. Lack of attention and not responding to their name by 6 to 9 months, or not showing a big joyful smile by 6 months old. Those are all very early signs that it could be autism spectrum disorder. Some more signs are with their speech. So if they're not babbling by age 1 or speaking their first word by age 1, if they're not combining 2 word like more please or want that or give me by age 2, then that's also a sign. And if at any point they start regressing in their speech or their social skills, so they were babbling, they were, making eye contact, they were doing this, that, and the other, and now they're not anymore, that is a big red flag. I would definitely see their doctor for that. The textbook mentions that they can be diagnosed as early as 18 months, which seems super early to me, but evidently they're doing more and more research and able to diagnose earlier than they used to be. Some of the motor abnormalities could be seen also as early as 6 months, like a head lag when you're helping a baby pull to sit up if their head is just falling backwards, or some like poor sitting balance. They're just kind of slumped over, that hypotonia, and that would be common in a lot of different disorders, not just autism, but it might be seen with children who have autism as well. As far as PT goes, we want to recognize the movement impairments like poor muscle tone or motor development or coordination or poor motor planning. And we want to foster early motor skills like posture control and object exploration, walking, sensory motor play, in order to help them develop the skills they need, especially to participate in play tasks, so that they're more and more likely um, to develop during those age appropriate ages, age appropriate stages, those skills that they need. Best practice, always get them family involved. With all pediatrics, you want the family involved. Early intervention is key. That's really with all diagnoses. The earlier, the better. If you get some intervention while the brain is developing, while the skills are developing, while they are in those key phases of development for specific types of development, if you help them during those phases, then it makes a huge difference moving forward. One example is I have 2 children that both had speech impediments. One did not get speech therapy until kindergarten, and for years had to continue to do speech therapy, and there were certain letters or phrases that you could still hear that there was a speech problem. The next child that had a speech problem, we got therapy at age 3, and within 6 months, you couldn't tell that there was any speech problem, and theirs was a lot worse to begin with than the first child. So that is just my experience, but I have seen it over and over. The earlier, the better. The developing brain is like a sponge; it's soaking everything up. Teach them, help them during that stage, and you will see huge gains very quickly. The longer you wait, the harder it is to get those gains. You always want to help the child engage and make it fun and imaginative, and with a goal of helping them interact with peers and get that social interaction in mind, even though, that's not necessarily something that a PT would typically write a goal about. If they're able to stand and run and jump and do those things, then they're more able to play with peers. And so all those things lead towards that goal. Some of the categories of intervention, there are behavioral intervention, and then there's developmental or relational intervention. These PTs don't necessarily do, but that's something they may be having in addition to other therapies. Motor imitation, of course, this is kind of a struggle area for people who have autism spectrum disorder. It's harder for them to watch and do what their parents are doing. Children typically will, watch peers or parents and just imitate what they're doing. But that doesn't come as easily. It's not as prevalent in children with autism spectrum disorder. And so encouraging that however you can, them to imitate, whether it's obviously they can do it through vocal, saying what you say, but in our specific realm, we're trying to get them to do what we're doing. And a lot of times they're more likely to interact with a screen than a person in front of them because there's a lot less input they're getting from the screen. It's two-dimensional, easier to process. So you may have them watch a video of a child, doing a movement and then see if they'll do it, rather than you doing it right in front of them. They're more likely to follow a video than maybe imitate what you're doing. One of the things you can also do in general is like hand over hand. So you're wanting them to do something and you can grab their hand and help them a few times and say maybe like reach, and this is good for any type of therapy, and then let go of them and say reach and see if they're able to do it without your help, if they will not imitate you, because that's when it gets a little trickier. One of the some of the motor behavioral problems that you'll see. So some are internalizing problems. So they may be more anxious. They may be withdrawn from their peers. They may be inhibited, not want to participate. Or you could see some externalizing problems. And most likely you'll see a little of both, where they're maybe a little more aggressive or maybe hyperactive or poor inhibition. So they see something and they just grab it, even though you're saying no or hot or, warning them that it's dangerous. And so both of those are common that you'll see. You'll also see more motor delays. And some of the studies show that children with autism between ages 2 and 6, not only do they demonstrate these behaviors, but their quality of life is affected. It's harder to have friendships and things when you are withdrawn and when you are not inhibiting. So you're just saying whatever you think. So that can affect their relationships and their quality of life. Here's just a little chart that kind of shows how gross motor delays and problems with daytime behaviors like attention and like controlling your emotions and things like that can negatively affect quality of life. So restricted play is sometimes due to some motor problems that we could help with in physical therapy. So this is something to take note of, is that if they have poor muscle tone, poor motor control, coordination, motor planning, then it's harder to play on the playground. It's harder to be involved in a sport. It's harder to, join in on a game that kids are playing together. And so the more we can work on those things, then the more likely they are able to participate and not as withdrawn, and the more physical activity they can get in, but also the more peer interactions they can get. These next few slides are just for your information. You're welcome to pause and read those, or read them in the PowerPoint I provide. But this is just a lot of different studies about pretend play and the importance of pretend play in children in general. But this is talking about autism. Using the system of least prompts to promote play. So trying to help them have choices and modeling the behaviors, given visual cues to help promote play activities or motor activities in the realm of physical therapy. Increasing the complexity of the play, getting peers involved, getting music is a great tool to use. If you can't get them to move or to calm down, music can help calm down somebody who's really high, or rev up somebody who is starting to fall asleep. So music is great at getting them to that, sweet spot for motor activities, but also for learning. Early intervention, this is just more studies and how early intervention helps children with autism. Positive behavior support, again, you can read through this. One of the things I do want to mention is it says timer. A visual timer is great because then there's boundaries. I'll give you this long to do this, and then they know what to expect, and they can see, oh, my time is running up, let me finish. One of the things I do with my children in general, my kids that I birthed and the ones that I treat for physical therapy, is the countdown. 5, 4, 3. I always say it and do it so they see it and they hear it, And at 1, whatever I've told them to do or to stop doing, then they need to do or stop doing. And if they don't, then I need to help them. So, like, let's say I'm saying, it's time to leave, let's go. And they're wanting to still play. And then I say, it's time to leave, 5, 4. And I make sure I'm close enough that if I get to 1 and they're not doing it, I can grab their hand and help them walk out. Or I can, take, if they're coloring or they're, grabbing something they're not supposed to or whatever, I can take that and say no. And I can like help reinforce that this means stop, like stop means stop. And you're at the end of your time frame. Or if I'm saying you need to, start this, it would work the same way. So hand over hand modeling of that behavior can be helpful in that situation. But that is one of my favorite tools. And once they get used to it, they typically respond pretty well to the countdown. So as far as interventions, there's just more studies talking about the benefits of physical activity, the importance of school-based interactions like peer modeling, social scripts, story-based interventions. And then there's mixed research about sensory integration and sensory-based interventions. I will say personally, from what I've experienced as a therapist, I think the sensory integration is huge. You have to get them less sensitive to squishy stuff in order for them to pick up whatever food and feed themselves. You have to get them less sensitive to something being in their mouth in order to help them brush their teeth. You have to get their feet less sensitive to the grass so that they will walk with their foot all the way on the ground. So it's huge in preparing them for different activities, whether the research says it or not. I'm a firm believer that it's very important. Aquatic therapy, like I mentioned, water is great. All that hydrostatic pressure gives you proprioceptive feedback throughout the entire body and allows you to, it like stimulates you to that sweet spot. It kind of calms down and revs up to that point where you are able to participate. It's great for adults and children alike. And you don't have to just like get in the water and splash around. I love these pictures because you can do all kinds of functional tasks. You can do reaching tasks. You can do different play with toys. They could be part way in the water. They could be all the way in the water. I mean, you have endless possibilities. What you can do on the land, you can do in the water. I love the top picture because they're also working on balance and core strength on a floating thing in the water and while doing a reaching task. I mean, that's super high level. So, I mean, not every kid's going to be able to do anything like that, but starting somewhere and just finding, what am I trying to work on? And you can incorporate aquatic therapy into that if that's an option at your clinic. Some basic areas of PT intervention. These are the same as pretty much with anybody else: motor skill, balance, coordination, posture, functional mobility, motor planning, physical activities, motor development, and play. One of the biggest things is with pediatrics, everything has to be fun. That was the hardest thing for me when I switched. I did a lot of obstacle courses and things because I'm not a fun person. I'm like, here, go do this and count to 12. I'm not like, let's imagine we're dinosaurs and roar and all this stuff. And so that was really hard for me when I switched to pediatrics. So I started doing a lot of obstacle courses and just setting the environment up so that it was fun and they saw it and wanted to do it. And a lot of times I wouldn't even have to prompt them. We walk into the area and they just start running through the course without me even having to make it fun. It was just inevitably fun. So for me, that was super helpful. But that's key in getting any pediatric patient to do anything you want them to do. Make it fun. All right, so this is some stuff we'll go over in lab and go through just what PT could look like at different stages of life for a child with autism spectrum disorder. And then there's some references and some acknowledgement to the person that also helped develop this PowerPoint in the book. So if you have any questions, let me know, and I will see you in the next lecture.